We'll welcome everyone to our webinar on affecting cost and value-based care. Our speakers today will be our own Molly Minahan, our Vice President of Operations and Innovation, and our client guest, AmeriWound's Christine Gray, who's our clinical quality. All right, and getting into today's agenda, I'm going to get into a little bit more detail about our two wonderful speakers, and then getting into the webinar itself. Today we'll be focusing on the quadruple aim, followed by cost under value-based care models and programs, diving into some VBC model cost requirements, and then finishing on how to impact cost. And then at the very end, we welcome a question and answer for all of our attendees. And then again, anyone that cares to ask any questions, please submit that via the chat box, as everyone will be muted. And of course, just to take care of that housekeeping, we do have our disclaimer here at the bottom. As far as our wonderful speakers today, as I mentioned, we have Molly Minahan, our VP of Operations and Innovation here at Reporting MD. Molly has been with us for almost 10 years now, while also bringing over 15 years of experience in data research, analysis, and reporting. And then we also have Christine Gray from AmeriWound, who works as clinical quality and billing auditor. She's a veteran in the industry with over 15 years of experience, and she is also a licensed practical nurse with a demonstrated history of working in the hospital and healthcare industry. And then I'm Jessica Raymond. I'm the Director of Marketing here at Reporting MD. And then a little bit about our two organizations. As far as Reporting MD is concerned, we have more than 18 years experience with patient outcome management for value-based care programs that deliver. We pride ourselves on our dedicated advisors who are here to answer any and all questions for our clients and potential clients while reducing physician, IT, and administrative burden. Getting into AmeriWound, they have served patients in long-term care facilities for close to a decade. It is currently licensed to provide physician wound care in 8 states, focusing on skilled nursing facilities, assisted living facilities, and independent living facilities. And we've had the pleasure of having AmeriWound be our client for 8 years now. All right, and I will pass this on to Molly to start on the webinar.
Hi, everybody. So the focus is affecting cost and value-based care. So we'll start with the quadruple aim. So in healthcare and before 2022, we focused on what the Institute for Healthcare Improvement coined the triple aim, which is better care for individuals, better care for populations, and reduce per capita healthcare costs. And more recently, and not surprisingly, given the strain on human resources in the healthcare setting, a fourth aim was added for improving the healthcare team's well-being. So the quadruple aim is only reached through the creation of a set of value-based care delivery models, new delivery models, which not only CMS uses, but commercial payers also use to improve the quality of care, and as it relates to the subject matter of this presentation, reduce the cost of care. So whether under the direction of CMS or commercial payers, the quadruple aim is realized through the value-based care models and programs being adhered to today. The charge for our healthcare providers and institutions is to refine and perfect workflows, processes, and quality care management to not only improve the wellness of individual patients and populations, but also slow the cost of healthcare and utilization through proper preventive and high quality care. So studies have shown that by improving quality of care for individuals, we've also seen relative cost of care reduce as well. And we know better management of chronic disease and better preventive care management have also been proven to reduce ED utilization as well as costly and traumatic hospital stays and readmissions. So I want to dive into a couple of value-based care models and more specifically really how cost impacts and plays a role in those value-based care models. So we'll start out with the MIPS program. So first, this is how cost impacts the MIPS score and resulting incentives and penalties on healthcare providers and practices/organizations. In 2022, cost is worth 30% of the MIP score, and it continues to be a 12-month reporting window. There's no submission requirement for the cost category under MIPS, as it's all calculated by CMS through administrative claims. There are a couple of different types of measures under the cost category. And I know this is a little bit of a distant category because it hasn't been scored in some time, but just getting back to the different types of measures, the cost, one is the cost of primary care, which patients receive, and that's known as the total per capita cost. The cost of services provided to Medicare patients related to a hospital stay. That's also known as the Medicare spending per beneficiary at the clinician level. And then costs for items and services during 23 different types of episodes of care for Medicare patients. We call those the episode-based measures. They've been adding, CMS has been adding those on since 2018 when they started to actually score cost. So in 2022, there are 15 procedural episode-based measures. There are 6 acute inpatient medical condition episode-based measures and 2 chronic condition episode-based measures. The measure type determines how the cost is attributed to a clinician based on the specification. So the specification will define that. And if practices don't have enough cases for any or all of the cost measures, they would not get scored on the cost category, and the points for that category would then get redistributed to other MIPS categories. So I do have a cost example or scoring example here. This mock practice reached the case minimum on 3 different cost measures: total per capita cost, elective PCI procedures, and an elevated MI with PCI acute inpatient medical condition measure. So depending on how the cost for each measure compared against the benchmark cost for the measure determines the measure specific score. And those scores are then tallied and then reweighted to or weighted to the 30% cost category weight under the MIPS total score. And so here you can see that they achieved, for the 3 measures, 17 out of 30 points. Since the category is worth 30% of the MIPS score in 2022, they would achieve 17 points for cost. So the Medicare Shared Savings Program, or MSSP ACO, is another value-based care model pushing on the quadruple aim in hopes of moving away from volume and more toward value and outcomes. It's an alternative payment model with the goals of promoting accountability for patient population, coordinating items and services for Medicare beneficiaries, encouraging investment in high quality and efficient services. And some of the factors that set an ACO entity up for success under the model are the minimum savings rate that's chosen at the point of contract, the level of risk-based contract, so what the risk is that you're taking for that ACO contract, and then success in achieving the quality requirements under the MSSP. In this case for 2022, that really revolves around reaching the quality performance standard. And the most significant factor, however, for success as an MSSP ACO is the management of cost. That is really about creating enough savings in order to share in the savings that were generated. And so in this chart, we can see that ACO 1, if you see here, the gray is the benchmark expenditure. So that's the benchmark. The blue is the total expenditures. And the goal as an MSSP obviously is to have your blue be much lower than your gray. And so ACO 1, these are true ACOs from the past. And so the first one did not generate enough savings to surpass their selected minimum savings rate. So they would not be able to share in any savings that they generated. So this gap was not enough to share in those savings. ACO 3 here had costs that exceeded their benchmark costs. So the blue was higher than the gray. And that means that this ACO had to actually pay back over $2.5 million in losses to CMS. And ACO 2 in the middle managed their costs to the extent that their costs were so far below the benchmark that the entity was actually able to share in the savings generated in the amount of nearly $4.5 million. So cost is clearly the key piece here. So we know cost matters. We know it's being measured, under all of these different value-based care programs. We know it can result in large penalties or even large incentives in some cases. But the big question is, how can you actually impact cost? And that seems to be a question that doesn't get answered. We see the facts about cost, but we don't really get the ideas on how to impact cost or how to move the needle. So next, we're going to take you through 6 different tactics that can help you manage and improve your costs. And then we'll summarize those at the end. So it doesn't need to be a black box. First, knowledge is key. It's important to know what cost data is available. So what's out there about your organization that you can analyze and consume. Under MIPS, for example, when cost is scored, CMS releases data including the patients and the episodes scored for each measure. So on the CMS QPP portal, it's called the Quality Payment Portal. If you log in, you can drill into each cost measure score to take a deeper dive into what contributed to your measure by measure cost scores. So if you look, here's some examples of what's out there. If you look at the graph, you can see your cost scores, how your cost scores compare to the cost benchmarks for each measure. You can also download lists of beneficiaries like you see on the bottom and their associated costs to understand where your highest costs were. So analyzing these cost data sets can help you understand who in the organization may be contributing the most to your cost scores, who's driving your cost scores up, who's driving it down, and what are the possible reasons why. It also stands to reason that the relative complexity of a provider's patient population will contribute to their costs. And it may help to understand why the costs of one provider might be higher or lower than others. So for example, here you can see on the chart, provider 1 had the highest total costs on the Medicare spending per beneficiary measure, but also had among the highest average patient HCC ranking at 79.16. So it makes sense that their costs are higher the more complicated their patients are. On the other hand, provider 2 also has higher costs, but the HCC ranking is lower. So why are provider 2's total costs so much higher, but their patients are less complicated than provider 1? This is the kind of information that's available and analysis that you can draw to see if you can start figuring out the trends and the places that you can look to figure out where you can start focusing on improving your cost and who in your organization maybe you need to start focusing on for working on cost. So number 2, the second tactic is annual wellness visits. Ben Franklin had it right when he said an ounce of prevention is worth a pound of cure. Healthcare payers are supporting, they're often even encouraging more preventive care measurement, like the annual wellness visit, and that obviously helps to understand and manage the total quality of care for individuals and patient populations. So annual wellness visits get the full chronic conditions profile documented for patients. They close a long list of quality care gaps. They create additional revenue for all of these different types of screenings and preventive measures. And so with so many payers, including CMS and commercial payers, pushing annual wellness visits, it's just one more pathway to reaching better care and reducing cost. And speaking with one of our 200 plus provider organizations recently, when any patient comes in for any visit, if they haven't had their annual wellness visit done so far during the year, they are completing it at that moment. They've already seen a huge increase in annual wellness visit adoption and an additional measure and additional revenue as a result of that. So this is a big one. Number 3 is risk scores and ensuring complete and accurate diagnosis coding. This is another big one. CMS utilizes patient complexity when calculating cost scores for a given year. So this is done using hierarchical condition categories or HCC coding. Commercial payers also use risk scores for payment rates, but with they're using the Office of Health and Human Services calculation model. It's a little bit different than the CMS HCC calculation model. Since a patient's complexity score restarts from 0 every single year, it's critical that accurate and complete diagnostic coding is utilized to ensure the payers understand the true complexity of your patient panel. Physicians should review and report all chronic conditions at annual visits. Physicians should not only report diagnoses that describe why the patient is being seen, but also diagnoses associated with chronic conditions that affect treatment choices. Reporting MD, we're calculating both the CMS and the HHS models to understand risk scores and complexity of patients for all payers. For example, the third patient on this patient list has a risk score of 6.31. They're not a Medicare patient. They have at least 2 known, so that the point being that they had their risk score calculated using the HHS model. They have at least 2 known open care gaps. They have 9 HCC relevant diagnoses that were unsubmitted to payers and no next appointment scheduled. So the payer doesn't know how complicated the patient is. They have known open care gaps, and there's no appointment scheduled for this patient, but their risk score is already at 6.3. The patient obviously needs further review and attention before a potential traumatic and costly event occurs. These are the patients that we need to pay attention to. So continuing with risk scores, under value-based care models like the Medicare Shared Savings Program, ACO, changing Medicare beneficiary risk scores will not only impact the performance period expenditures, but also the historical benchmarks that costs are compared against. Accurate diagnostic coding means accurate risk scoring, which leads to improved shared savings potential and reduced loss potential. If an MSSP ACO doesn't exceed their preset minimum savings rate, like I showed before, or if their costs are higher than their benchmark, like ACOs 1 and 3 that we saw before, they won't be able to share in savings generated, and they could even be liable in CMS for losses. So the risk scores impact benchmarks. Not documenting properly will result in lower benchmarks and will reduce possibility of savings. So looking at the impact of risk scores on Medicare Advantage, specifically the PM rates, those are the per member per month payments. The higher scores translate into higher PM payments. The lower scores translate to lower PM payments. So if we take a patient case study, the patient has a BMI of 44. The patient should be coded with a morbid obesity diagnosis code because they're just coded as just obese, and which means that there's no change to their risk adjustment factor, otherwise known as their RAF score, and therefore there's no change to their Medicare Advantage payments. So the same patient, however, being properly diagnosed with the morbid obesity diagnosis code, gets an adjusted RAF score, which increases their PM payments by nearly $300 per month and over $3,500 per year. The Medicare Advantage programs that have inaccurate or incomplete HCC scores will definitely suffer financial losses due to underestimated complexity being represented for their patient population. Number 4 is ED visits and hospital readmissions. So pay attention to ED visits and hospital readmissions as they equal higher utilization. We all know this. Of course, an ounce of prevention is key. So pushing annual physicals, annual wellness visits to prevent ED use is important. When it's not enough, a few ways to target frequent ED use is to offer after hours care, or phone lines, reserved times for same-day office visits and telehealth visits, and offering those. If you're a MIPS participant, CMS releases information on ED utilization as well through the QPP portal. So Some practices are measured on administrative claims-based measures like the measure hospital-wide 30-day all-cause hospital readmission for MIPS groups. The top right hand image shows an example of a practice that scored quite high with a 0.1416 performance rate. The lower the readmission rate, the higher the score. So here you can see that the score resulted in 9.24 points for that measure. Additionally, the items and services information, as seen in the bottom image, shows metrics on ED utilization. And I showed you here where you can find that information in the QPP portal under items and services. And that shows metrics on ED utilization from a given reporting year. So you can compare this type of information from year to year. It can give you insights on what's needed to initiate improved ED utilization across your patient panel. So patient care coordination is number 5. First, get everyone talking. Care coordinators keep communication among caregivers open and up to date. This includes verbal, written, digital forms of communication so that caregivers are up to speed on the agreement and in agreement on patient care. Get everyone sharing. Ensure that patient referrals are shared amongst caregivers. It could include formal agreements or contracts with other providers and organizations in your area to share that patient information. Get everyone meaningfully using certified EHR technology or CERT. CERT offers electronic referral capabilities. Make sure your team members and other caregiver partners are taking advantage of those EHR capabilities. And that one is a 2-for-1 because it also helps the PI category measures under the MIPS program when you're meaningfully using your certified EHR technology. So finally, the collection of social determinants of health can be done through assessments and screening tools and via individual self-reporting. When documented in the diagnosis list, social determinants of health can contribute to improved patient complexity documentation. While they don't currently impact reimbursement, these diagnosis codes can trigger referrals to social services and other services which can help to reduce health inequities and prevent traumatic ED visits. At the top of the graphic, you can see that ICD-10 codes Z55 through Z65 are used for social determinants of health, and each one is shown in the related graphic below. So Z55 you can see is for education and literacy, Z56 is for employment and unemployment. So social determinant of health coding can reduce health inequities, and more value-based care models are focusing on them. So, for example, the CMS model, formerly known as direct contracting, which is now known as the Accountable Care Organization Realizing Equity, Access, and Community Health, also known as the ACO REACH model. The focus of that model is to improve the healthcare experience of people with Medicare, Medicaid, and even marketplace coverage. And the method is to use this model to identify underserved communities and then initiate processes to reduce health disparities within those patient populations. So, social determinants of health coding can result in those reduced health inequities. Continuing on that theme, CMS is rewarding up to 3 grants totaling $1 million to support research. 3 different grants totaling $1 million to support research being done at eligible minority serving institutions, MSIs, on how CMS can better meet the healthcare needs of CMS beneficiaries. This opportunity would support research on programs, policies, operations, and more that influence health equity. The deadline for applications for those grants is 3 p.m. on Thursday, July 28th. You can get a little bit more information. It's really about supporting researchers that are exploring how CMS can better meet the healthcare needs of CMS beneficiaries, especially those in underserved communities. We have the website here at the bottom as well. So cost does not need to be a black box. It's not a quick fix, but it doesn't need to be a black box. So first, knowledge is key. Know what data is out there to understand your baselines and whether or not you're improving, or if you need work on various cost-related measures. Second, strengthen your preventive care with annual wellness visits or preventive care visits. That's also a 2-for-1 because it brings in additional revenue for the visit or for the screenings as well. 3, ensure accurate diagnosis documentation for improved risk scores, making sure you're communicating the true complexity of your patient population to payers through accurate diagnostic documentation. Offer alternatives to the emergency department. After our phone lines, 24/7 access to providers, same-day office visits, telehealth visits. These are all pieces and alternatives to ED utilization and can really cut that down. Focus on coordinating care with other providers and surrounding specialists. Get everyone communicating to improve the complete patient care continuum. And finally, social determinants of health may not change payment rates today, but accurate documentation of these can trigger social services and other referrals and interventions that can help reduce health inequities. So with that, Jess, do you want to introduce Christine?
Sure, absolutely. Thank you, Molly. So yes, now we have our guest and client, Christine Gray from AmeriWound, who just will have a few minutes about their correspondence with Reporting MD.
Hi, thanks, Jess. Thanks, Molly. I just wanted to say that my experience working with Reporting MD has been phenomenal. They have been there every step of the way for me. I've been with AmeriWound for a little over going on 3 years now. And they have been exceptional in helping me to find my quality measures. Any questions that I have, they're always available. We service 8 states, and one of the states we finally submitted to CMS this past year through Tom, and being able to use that aspect of your services as well has been great. We scored 100% on that state. That state was never filed for our company before. So greatly appreciative of all your help with making that dream come true. So now I have to find a few more dreams that you guys have to make come true. But it's really been an excellent opportunity to be able to work with all of you.
Thank you, Christine. We appreciate that.
Thank you.
All right, Jess, so let's move to Q&A.
Yeah, absolutely. And again, if any and all questions are welcome, just submit those via the chat since everyone is muted, and we can get that rolling. As far as what has already been submitted or submitted ahead of time, we'll start with, is there a way for providers addressing SDOH in a health system to be reimbursed in a value-based care model?
So as it stands right now, SDOH does not impact reimbursement, but that doesn't mean that there's not, it's not in the future. We know that it's critical to help reduce those health inequities across patients. Coding these, getting used to coding these is probably a good idea now. And again, it can bring those additional referrals, social services, and other things to the table that may not have been available or known about that can help reduce, ED utilization, readmissions, all of that. So right now, not a lot of immediate payment reimbursement for SDOH, but it's on the horizon.
All right, next we have, how do we know what our budgets are?
So, sorry, I'm just going to get down to the QA. So I think, Medicare spending per beneficiary, that one's easy. You know what your benchmarks are. So the key with that is making sure that you're accurately coding for the risk scores and keeping those risk scores up, because when you stop or you decline on that or aren't doing, the chronic conditions, that means that your benchmark is going to start getting impacted. So your benchmark is key under MSSP ACO. Under MIPS, unfortunately, cost hasn't been scored for the last couple of years due to the COVID pandemic. It's good and bad. It's bad because we don't really have all the cost information that CMS can provide to us. So that one's a little bit tougher. I think generally speaking, we're going to have more insight, more information when we do get scored on cost, and hopefully 2022 is going to be a different year. So getting those benchmarks is key, though, and go into the QPB portal, take a look at even 2019. Take a look at some of the resources that are out there. You can see hospital information. You can see, for the different measures, Medicare spending per beneficiary. You can dive in and you can get the beneficiary list for the measures that were the patients that were used in the scoring of any measure that you were scored on in 2019.
Great. And next, for annual wellness, do you have recommendations on tracking?
On tracking. So I'm trying to think of specifically. So I think there are a couple of different ways. There are organizations like Reporting MD. We actually offer a measure where you can actually we will aggregate for the 3 different annual wellness visit types that are out there. So the initial, the subsequent, and the IPPE. We will aggregate for those and give you performance information so you can actually measure that, and you can see your performance on annual wellness visits throughout the year. I think that, it really depends on the EHR or the system that you're using. But some systems do offer annual wellness visit, but making sure that you're taking advantage of sending out letters to patients about annual wellness visits and coming in. Like we said, with that big organization, we were just speaking with them the other day. They mentioned the fact that they have not done well on annual wellness visits. It just has not been a focus in the past. And they said this year they were going to do something different. If the patient came in, they were seen for any reason, and they did not have an annual wellness visit scheduled or had been done in the year, they were doing it at that moment. That's a huge time requirement. It's a big initiative. But because of that, they know that they're going to get better coding, they're going to get better documentation, they're going to reduce the possibility of ED visits, and they're going to bring in additional revenue for all the screenings. That's preventive medicine at its best. So really excited to hear about that. But utilize what your systems offer. Make sure you know all of what your systems offer. Send out mailers to get patients to call up. A lot of patients don't even know what the annual wellness visit is. And talk to Reporting MD. We have resources out there as well that just have a quick slide deck that takes you through just an easy to read annual wellness visit brief that you can send to anyone. I send it to my mom and dad. So we have resources. We're measuring annual wellness visit. We're measuring annual wellness visit and the gaps from year to year. Know what your EHR is capable of. And yeah, I think that's probably the best advice for that.
I think the final question will be, how is COVID affecting costs?
So I do have a slide about this. It kind of gives you an idea of what has happened over the last couple of years from under the MIPS program, for example. For cost in both 2020 as well as 2021, the cost category was reweighted. That means that nobody was scored on cost. In fact, we just found out, a couple of months ago, 2 months ago, after the submission season, that cost was not going to get scored for 2021. When that happens, that means that the cost category ends up being worth 0%, and the points get redistributed to the other categories. So for 2021, quality for large practices becomes actually for all practices. When cost is the only category that's reweighted, quality became worth 55%. The PI category added on an additional 5% and became worth 30%. The additional thing about cost not getting scored, like I said before, is just that the resources aren't out there. The QPP portal is one of the best CMS resources available that I've seen. You know, going back to the years of IACS and things like that, you know, the QPP portal is just so welcome. There's so much good information in there, and it's really tough when the same information is not released when the cost category is not scored. The extreme and uncontrollable circumstances hardship application that is available this year in 2022 as well. So if you are still getting impacted by the COVID pandemic, you do have the opportunity to get one or a couple or all of the MIPS categories reweighted. And because we don't know if cost is definitely going to get reweighted for 2022 across the board again. So if you do want to have that happen, know that you can apply for a hardship application, but also know that if you do that, you are confirming that you will not get scored on the cost category, and that means that you will also not have access to any of the information on how you're getting scored on the measures or the beneficiaries that are contributing to your cost scores.
Well, again, just want to, thank you, Molly and Christine, for your time today. Thank you for everyone that did attend. As far as some follow-up, if you were interested in a one-on-one meeting, we are happy to schedule that for you. Also, I will be emailing the attendees the slide deck, and then the full presentation will be available on our website probably by the end of the week as well. So again, thank you very much, everyone.
Thank you.
Thank you.